Hello. Let's see now how a drug crosses a membrane. What is called passage of drugs across cell membrane, or the permeation of drugs. We're going to go quickly through this, how drug crosses a membrane. The first method is passive diffusion, which could be aqueous diffusion, which is along the concentration gradient, or it could be lipoid diffusion, especially for weak acids and weak bases. The second method of permeation is filtration, and this mostly happens through aqueous pores which are present in the capillaries. The third method could be a specialized transport. This could happen with the help of a carrier, that's carrier mediated transport. Next one could be active transport, which could be primary or secondary, and the last one is pinocytosis, which will lead to endocytosis or exocytosis. Let's go to aqueous diffusion. What happens is the small water-soluble molecules, they pass through the aqueous pores, and it's a long concentration gradient. If you look at the slide, I have highlighted, I have underlined particular words in this which are going to be helpful for you to solve your multiple choice questions. Aqueous diffusion is regarding the small molecules, water-soluble molecules, and is along the concentration gradient. It's governed by the Fick's law of diffusion. What is this Fick's law of diffusion? Look at the formula. If you look at this formula, it shows you that the thickness of membrane is in the denominator. So more thick is the membrane, less is going to be the permeation. And area of the absorbing surface, area of permeation, is in the numerator. So more the area of permeation, more the absorbing surface, better is going to be the permeation of drug across cell membrane. Let's have a look at it. This is lipid bilayer. There is hydrophilic heads and hydrophobic tails. Now large uncharged molecules, they are not allowed because they are large, that's why they are not allowed. Let's see if the molecule is small but it contains a charge, what happens? It's also denied, which is telling you that if you are small, you are easily allowed. If you are uncharged, if you are non-ionized, you are easily allowed. Let's keep this in mind at the back while discussing the next one, that is called lipoid diffusion, which is practiced by weak acids and weak bases. And there's a complex word for this, equation for this is called Henderson-Hasselbalch equation. pKa is a constant, which is the pH at which 50% of the drug gets ionized. For weak acids, it will be logarithm of ionized form divided by non-ionized form equal to pH minus pKa. And for weak bases is going to be the reverse, logarithm of non-ionized form divided by ionized form. Let's stay at this particular slide, at this particular equation for some time, and let's read again what is pKa. Is the pH at which 50% drug gets ionized. Let's suppose, for example, the pH is 3 and the pKa for a particular drug is also 3. So it's going to be 3 minus 3. Obviously, at this particular state, 50% of the drug is going to be ionized, 50% of the drug has to get non-ionized. Acidic drugs will be obviously better absorbed through the stomach because the stomach has acidic pH, the drug is acidic, so the drug cannot get ionized. It remains less ionized. So if you are less ionized, you can easily cross and you will be absorbed. In the same way, if the drug is basic, is an alkali, is going to be better absorbed through the intestines. They will be less ionized at basic pH, that's why they will be better absorbed. We are not learning this just for the sake of understanding the theory. It's got a great application. For example, let's see if you get a poisoning, an overdose of a weak acid. For example, say salicylates or weak acids. So if someone eats more number of aspirin tablets, you call it acute aspirin overdose or acute salicylate poisoning. This is a weak acid. Now if you want to throw it out of the body, you need to increase the ionization. It's an acid, so if you want to increase the ionization, you should put alkali into it. And this is why what you start doing is you do alkalinization. You give a substance which is going to alkalinize the plasma, alkalinize the urine, and such a substance is NaHCO3 or sodium bicarbonate. So you get aspirin overdose, you get barbiturate overdose. These are weak acids. you need to give an alkali, because when an alkali is added to the acid is going to get ionized, and once it is ionized, it's not going to be absorbed. Reverse is for weak base, and we have an example of amphetamine or PCP. These substances are weak bases. If you want to excrete them, you need to acidify the plasma or acidify the urine, and for this the substance commonly used is ammonium chloride or NH4Cl. So this is the direct application of Henderson-Hasselbalch equation. Next we go to filtration, which happens through aqueous pores, and there are paracellular spaces of about 40 angstrom size in the capillaries, for example glomeruli, and you never get these kind of big spaces in the brain. So it's very difficult to penetrate through the brain. This particular gradient is hydrostatic or osmotic pressure gradient, and if the blood flow is high, is going to be better filtration. That's the rate of blood flow is going to determine the filtration. Next we go to the specialized transports. The first one is facilitated transport. This happens along the electrochemical gradient, and it is carrier mediated. There's no energy required. The carrier takes the drug inside. In the central nervous system, you have amino acid carriers, and you also have GLUT4 glucose transport molecules. The next one is active transport. We are saying active, so it can happen against the electrochemical gradient. Let me take you back to the previous slide. Facilitated transport, no energy, and it's carrier mediated, so it happens along the electrochemical gradient. When it becomes active transport, it needs energy, and it is against the electrochemical gradient. From where do we get this energy? Number one, by the hydrolysis of ATP. If it happens, it's called primary active transport. And if you derive the energy out of exchange of another ion, which is called symport or antiport, then it's called secondary active transport. We come to the last part, and that's called pinocytosis. That is either exocytosis or endocytosis. You would have special proteins to carry a substance. For example, B12 is carried inside with the help of intrinsic factor of Castle, or iron is transported with the help of a protein called transferritin. What about blood-brain barrier? I just mentioned blood-brain barrier does not have big spaces in the capillaries. The cells are tightly packed around the capillaries. So if you want to cross this barrier, as I said, behave like a Roman in Rome. You have to be more non-protein bound. You have to be more non-ionized, and you have to be highly lipid soluble. I'll say it again. If the drug is highly lipid soluble, non-ionized, and non-protein bound, the drug is going to cross the blood-brain barrier easily. You can have more transporters there, like P-glycoprotein transporter, which is called PGP, and you also have anion transporters. There is one interesting thing about blood-brain barrier. If the blood-brain barrier, if the area is diseased, the drug should cross better or the drug should cross less. What we would feel is, because it is diseased, the drug is going to cross less. But our guess will be wrong. Because whenever there is disease, say inflammation, it's going to increase the blood flow. So a substance which normally cannot pass through the blood-brain barrier is going to be transported very fast because there is increased rate of blood flow. I'm just reminding you of the original Fick's law of diffusion. When you have more rate of blood flow, you can be transported easily. So please remember, substances like aminoglycosides, which normally do not cross blood-brain barrier easily, can get penetrated if there is meningitis, because there is inflammation and there is increased rate of blood flow. So also, one more important fact about blood-brain barrier is, it is deficient at the chemoreceptor trigger zone. That's the area postrema. You don't have to cross the blood-brain barrier to reach the area postrema. Even if you are someone who is less lipid soluble, you can reach the area postrema. There is no blood-brain barrier there. We will discuss this when we discuss the anti-emetic drugs. Is going to have a lot of implication at that place. Next, we pass on to the placental barrier. Placental barrier is a lipoidal barrier, and normally the lipophilic substances, more lipid soluble substances, are allowed. But the substances which are hydrophilic, not lipid soluble, if you give them in large amount, and for a long time they also get transported. What means by this is the placental barrier is an incomplete barrier, and you have to be very careful while administering the drugs to a pregnant woman. Placental efflux P-glycoprotein transporter is there to protect, is going to throw the toxic substances out, but still it's an incomplete barrier. What's the application of this? The application of this is teratogenicity. Terat is a monster, which means it's going to produce structural abnormalities in the fetus. 18 to 55 days is considered in general as the period of organogenesis, when the organs are getting developed. So, if you give a drug which crosses the placental barrier and is toxic to the fetus, is going to produce structural defects or deformities, especially if you give the drug between this period is 18 to 55 days. From 56 days onwards, what usually happens is the functional abnormalities, because most of the organ development is over by 56 days. I'm saying most of it is over. Let's see at the implications of placental barrier. If you give the drugs during first trimester, what are the drugs which produce structural deformities or teratogenicity? A very classical worldwide known example is thalidomide, producing phocomelia, is the seal limbs. Phenytoin, an anti-epileptic drug, produces neural tube defects. Warfarin, an oral anticoagulant, also produces structural defects, that's depressed nose, eye and hand defects. It's an anticoagulant. So if you have a pregnant woman, she needs anticoagulation, please don't prescribe warfarin. The drug of choice, anticoagulant drug of choice for a pregnant woman is always heparin, which does not cross the placental barrier. Next you have tetracyclines, which are known to produce the abnormalities in the teeth. Let's come to the second and third trimester. You get mostly other complications, like an oral anticoagulant like warfarin produces fetal hemorrhage if given during second and third trimester. Morphine given in the third trimester produces respiratory depression, and the oral anti-diabetic drugs can precipitate hypoglycemia in the fetus. There are some more very important drugs which are going to be asked during your multiple choice questions to identify what abnormality this drug is producing. We are going to see about all these drugs when we go to the details of that particular system, but here, as implication of placental barrier, we need to remember lithium, which produces thyroid dysfunction, so there could be fetal goiter. Then alcohol, most important, one of the single causes of mental retardation in the fetus and growth retardation. Angiotensin converting enzyme inhibitors, AC inhibitors, that's captopril, enalapril, ramipril, etc., which are worldwide used for heart failure and hypertension, can produce hypoplasia of organs. Right now I'm giving you the hint. A pregnant lady needing an antihypertensive agent, never prescribe an ACE inhibitor, which is supposed to be on the topmost list of antihypertensive drugs, should not be prescribed if the lady is pregnant. Indomethacin produces premature closure of patent ductus arteriosus, and tetracyclines can produce teeth discoloration. Just the pregnancy is not important, also the lactation. And there's milk barrier. If there's a woman who is breastfeeding her infant, the drugs can cross the milk barrier and they can be toxic to the infant. Drugs taken by the mother can cross the milk barrier and can affect the infant. Let's remember some important things. The first line of the slide tells you 3 A's, that's amiodurone, amphetamine, and most of the anti-cancer agents. The next line is telling you 3 C's, that's chloramphenicol, ciprofloxacin, and cyclosporine. Apart from this, if you go to the next line, it's quite easy to remember are the hormones, estrogens, androgens, and prednisolone. And the last line, 2 important substances, lithium and metformin. These can produce abnormalities in the breastfed infant because they can easily cross. Next we go to enterohepatic recycling. There are a few drugs which practice this. From the intestine through the portal vein, they go to the liver. From the liver again to the bile duct, again to the intestine, and again absorbed. These drugs are going to remain in the body for longer time and are going to produce a longer effect. And there are some examples. morphine, buprenorphine and methadone from the narcotics, indomethacin and piroxicam from the non-narcotics, and you have digitoxin, phenytoin, diazepam, as well as tricyclic antidepressants and chlorpromazine. Now we go to absorption. Absorption and bioavailability go hand in hand most of the times as far as the oral route of administration is concerned. I'll first summarize the factors which affect the absorption and bioavailability. It is going to be between the drug and the body, naturally. The physical properties of the drug, that's the first important factor. It contains the physical state, whether it's solid or liquid, what's the water solubility or lipid solubility of the drug. The second one is not just physical property, but what's the nature of the dosage form. It's supplied in what particular formulation. So it will decide what's the particle size. If the particle size is small, it is going to be disintegrated and dissolved fast, and it's going to be absorbed early. So particle size, disintegration time, the dissolution time, and of course the route of administration by which you are going to give the drug. And third is the patient, is the person who is going to receive the drug. So we call it either physiological factors or pathological factors which are present in the human being. This will include what's the pH of the medium, what's the state of ionization of this particular drug in this medium, the gastrointestinal transit time. Are there any other substances present in the stomach along with this particular drug? For example, food and tetracyclines, they can affect the absorption. Calcium, magnesium, aluminum, phosphorus, iron, they can affect the absorption. The surface area, what is available for absorption. Let me remind you of Fick's law of diffusion. More area, more absorption. The circulation and the blood flow. If the blood flow is better, absorption is going to be better. What's the state of metabolism? Whether there's going to be first pass metabolism, so metabolism. Then the genetic factors which can modify the absorption, and whether the patient has any disease, the presence of disease. So this is regarding all the factors affecting the absorption and bioavailability. And then let's get introduced to an important term that's called biological half-life, what is called T-half. You might have heard biological half-time. Now we are going to the living being, that's why we're calling it biological half-life, is the time required for original concentration of the drug to fall to its half. I gave 100. In how much time is going to become 50 is going to be the half-time of the drug. If the half-life of a drug is short, you might need frequent dosing. You'll have to give it more number of times a day. If there's hepatic disease, then the half-life of the drug may get prolonged because the metabolism of the drug gets affected. And if a drug has got high plasma protein binding, then it's going to produce a longer half-life. But please remember, the half-life is independent of dose. If I give 100, the time required for 100 to become 50 is going to be the same if I give 50 and calculate the time required for 50 to become 25. So the half time is going to be independent of dose. You can also apply this particular term, the half-life or the half-time, to a process. Time required for any process to come to its halfway can be also called as the half-time for the process. For example, you can call it elimination half-time, absorption half-time, so on and so forth. There's one important formula which you might need sometimes. The biological half-time is equal to 0.693 multiplied by the volume of distribution divided by clearance. We are going to make use of this formula as and when the time comes. Let's have an example. A drug has half-life of 10 seconds. I hope you are reading. You give a dose of 6 milligrams. After 30 seconds, how much of the drug remains? Remains inside the body. So look at the dose is 6 milligrams and its half-life is 10 seconds. Let's do it. At time 0, the drug is 6 milligrams because you gave 6 milligrams. Half time is 10 seconds. So after 10 seconds, this 6 is going to become half, that's 3. After another 10 seconds, that's total 20 seconds, 3 is going to become 1.5. And after another 10 seconds, that at 30 seconds, this 1.5 is going to become its half. So that's 0.75 milligrams. This is how you find out after each half time what's going to be the concentration of the drug inside the body. Let's do it thinking that the initial amount is 100. initial amount given is 100. And let's do the same exercise what we did just now. So at time 0, the concentration of the drug is 100. Now after 1/2 time, it will become 50 because 50 gets excreted. So 50 has gone outside. Total excreted until now is 50. After one more half time, this 50 is going to become 25. The excreted is 25 right now, and the total excreted is 50 at the last half-life and 25 just now. It becomes 75. It means 75 is out of the body at the end of 2 half times. After one more half time, 25 will become 12.5. 12.5 will get excreted, and the total excreted becomes 87.5. And at the 4th half time, the concentration will become 6.25, excreted will be 6.25, and the total drug gone outside the body is 93.75. What I did was, I asked you to take the initial amount as 100, because about all this we can straightway apply a word percentage. Look at the miracle. We don't know which is the drug, we don't know for what disease we are giving it, but still I can say, if I know the half time, at the end of 4 half times, 93.75% of the drug is outside the body, is excreted by the body. So there is near complete elimination. It means almost complete elimination at the end of 4 half times. Naturally, at the end of 4 half times, the amount of the drug inside the body is negligible. It's just 6.25%. So if you want to achieve a constant plasma concentration, you must repeat the next dose of the drug before completion of 4 half times. And this becomes the basis to decide the frequency of administration of the drug. Some drugs are given 2 times a day, some are given 3 times a day, some 4 times a day. It is going to be decided by the half time of the drug. What is volume of distribution? Imagine if the concentration of the drug throughout the body remains same as the concentration in the plasma, which is practically difficult. When you give a drug, a lot of it is going to be in the plasma and some amount will be in the tissues. But suppose we imagine the concentration of the drug throughout the body remains same as the concentration in the plasma, then the volume needed to accommodate all this drug is called as volume of distribution. And this volume of distribution determines what's going to be the loading dose for a drug. For example, total amount in the body divided by plasma concentration. Let's do it for drug A. The concentration in the plasma is 3 and in the extravascular compartment remaining body is 27. For drug B, 27 is in the plasma and 3 is in the extravascular compartment. So for drug A is going to be total amount in the body, that's 3 plus 27, 30, divided by 3, that's present in the plasma, is going to be 10. For B, again the total is 27 plus 3, that's 30, divided by the amount in the plasma is 27, that's 1.1. So for drug A, the volume of distribution is 10, which means it gets more distributed in the tissues, in the extravascular compartment. Whereas drug B has got a small volume of distribution, which means it is comparatively less distributed in the tissues and it remains in the plasma. I explained to you what is volume of distribution, but it's practically difficult to find out the total amount of the drug in the body by going to the various spaces. And naturally, we have to come to a practical solution for this is whatever you give is the total amount in the body. Let's just presume that whatever I am giving is the total amount. So the dose administered by intravenous route, which is going to give 100% bioavailability, I take it as amount in the body and just divide it by plasma concentration is going to give me apparent volume of distribution. I can't say it's the definite volume of distribution, but it's apparent. So for an example of a drug having plasma concentration 50 milligrams per liter and the dose given by intravenous route is 1000 milligrams, the apparent volume of distribution becomes 1000 divided by 50 and that's going to be 20 liters. This volume of distribution, if high, it's called non-homogeneous distribution because the most of the drugs is in the extravascular tissues. And please remember 3 examples: chloroquine, which gets deposited in the liver and retina, digoxin in the heart, and warfarin. Whereas if the volume of distribution is less, it means it remains more in the blood. It's called as homogeneous distribution. The factors affecting distribution are obviously the lipid solubility, ionization, and the pH, the plasma protein binding, the affinity for tissues and the accumulation, the regional blood flow, and the body fat. If you have a lean body fat, lean body mass, it's going to affect the body fat. Of course, changes with age, and the conditions like heart failure, uremia, and cirrhosis are going to affect the volume of distribution. Those drugs which have a high volume of distribution can also get stored in the tissues, and it will be difficult for them to get removed from these tissues. So tetracyclines in teeth and bones, chloroquine in the retina, streptomycin in the vestibular apparatus, and emetine and digoxin in the heart, amiodurone in the thyroid, and dapsone clofazimine in the skin and reticuloendothelial systems is going to be the accumulation of the drug, or the accumulation of the drug in the various sites, which you call as tissue storage.